Good day, everyone. I am Dr. Noreen. Together with my co-authors, Dr. Vicente Gomez and Dr. Francis Fernandez from Makati Medical Center, Philippines, I am presenting to you my paper on unusual presentation of extrapulmonary tuberculosis in a child. Tuberculosis infects approximately 23% of the world. It usually affects the lungs, but extrapulmonary tuberculosis can occur in 5% of the pediatric population. Likewise, polyostotic fibrous dysplasia can present in about less than 1% of the general pediatric population. Diagnosing extrapulmonary TB may be a challenge since most have less experience in diagnosing extrapulmonary TB and that it has similar manifestations with other diseases. Knee is the third most common site affected. The main treatment for extrapulmonary TB is still chemotherapy. However, if functional limitations and bone destruction already occur, surgery is indicated. Previously, arthroscopy was an unlikely option for this age group due to the lack of instruments and lack of experienced surgeons. But due to the advancement of technology, arthroscopy in pediatrics became generally recognized. So we have MT, a 3-year-old female who came in with swelling and limitation of motion of the right knee. This patient is well nourished and fully vaccinated, including BCG. And at 1-year-old, initially presented with left mandibular mass, initially diagnosed as polyostotic fibrous dysplasia in a local institution. Biopsy was done, which revealed benign granulomatous lesions, negative for AFB and MTB gene expert. And at 2 years old, presented with sternal mass with intermittent fever for 1 month, again did biopsy, which revealed fibrous dysplasia, and had complete workups, including genetics and TB in the USA, which were all unremarkable. Antibiotics was given for fever and eventually lysed. And at 3 years old, presented with gradual enlargement of the right knee with limitation of motion and difficulty in ambulation, had intermittent fever and multiple erythematous lesions, and enlarged digits of both hands. So this is the pre-op picture of the knee and has multiple erythematous lesions on the left shoulder, right elbow, left eyelid, cheek, and arm. Right knee X-ray showed soft tissue shadow around the joint. Right knee MRI showed diffuse knee synovitis. Both hands X-rays also showed fibroosseous cystic lesions on the phalanges of all fingers. So we did a diagnostic arthroscopy, debridement, and synovectomy of the right knee using a 4mm 30-degree scope with 4 portals. Arthroscopic findings showed bleeding nodular synovitis. Synovium showed positive MTB gene expert. Cultures showed no growth. Histopath results showed chronic granulomatous inflammation consistent with TB process. Post-operatively, patient was started on anti-COX treatment for 12 months, 2 HRZE and 10 HR, placed on long leg posterior splint and discharged on post-op day 2. And after 2 weeks, the splint was removed and noted decrease in the size of the knee. Patient has full knee range of motion and is ambulatory. And over a month, patient showed dramatic resolution of symptoms, skin lesions disappeared, and patient started to run. And currently, at 7 months post-op, no complaints of pain, swelling, and no difficulty in daily activities. Subsequent X-rays also show that the lesions on the fingers and mandible decreased in size. Multifocal cystic bone TB, also known as Jungling's disease, is a very uncommon variety of TB osteomyelitis. Multifocal bone lesions are frequently diagnosed as polyostotic fibrous dysplasia, especially in centers that TB is very uncommon. Awareness of this condition is likely increasing, although it has not yet been reported. This shows that TB osteomyelitis has many presentations, and suspected multifocal fibrous dysplasia can be one of them. Proper diagnosis and early treatment are important to have a successful management and prevent development of further complications. Radiographs are not consistent in diagnosing TB osteomyelitis. There are only 8.1% that forms new subperiosteal bone and lytic lesions, while only 31.1% have evidence of pulmo TB in chest X-rays. MRI is more reliable where marrow signal changes can be appreciated. There are various serological and biological tests that can help in the diagnosis. However, these are still not 100%. ESR is always elevated when there is inflammation. AFB staining has sensitivity of 25 to 75%, while AFB culture has sensitivity of 48.6 to 80%. PCR is an effective and rapid diagnostic test for TB. It has a sensitivity and specificity of 78.6 to 100% and 71.4 to 87.1% respectively. Biopsy is the gold standard for diagnosing TB, as it can give tissue diagnosis and at the same time rule out malignancy and other diseases. Diagnostic problems are common in bone and joint TB since it has unusual presentations. Several factors include decreasing incidence of bone and joint TB, Nature of TB osteomyelitis is changing, unusual sites of involvement, lack of pulmonary disease, and lack of classic radiographic signs. In symptomatic bone and joint TB, we can combine diagnostic and therapeutic with the use of arthroscopy. We can get adequate specimens to be sent for proper diagnostic and provide immediate symptomatic relief to the patient. Advantages of arthroscopy, which includes minimal skin incision, less tissue trauma, faster recovery, and shorter hospital stay. This is the first reported case of a patient with multifocal TB previously diagnosed as a suspected fibrous dysplasia that showed complete resolution of the lesions after arthroscopic management and chemotherapy. We hope that this increases an awareness that TB osteomyelitis has many presentations and suspected multifocal fibrous dysplasia can be one of them. We are encouraging arthroscopic therapeutic and diagnostic synovectomy for suspected bone and joint lesions in children, including the very young, as it is less invasive and can render a therapeutic treatment. Extra-pulmonary TB, especially multifocal cystic bone TB, has unusual manifestations and can mimic a lot of diseases. It can cause delay in the diagnosis and therefore the proper treatment. TB must always be considered in cases presenting with osteolytic bone lesions and systemic manifestations. Knee arthroscopy is a good option in treating hard-to-diagnose cases, since it can both be diagnostic and therapeutic at the same time. Diagnostic and therapeutic arthroscopic synovectomy is highly recommended for suspected bone and joint lesions in children, including the very young, as it has minimal skin incision, less tissue trauma, faster recovery, and shorter hospital stay. And these are my references. Thank you.